Hello, everyone, and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders, past and present. I extend that respect to Aboriginal and Torres Strait Islander people listening today or in the future. My name is Rebecca, and I will be facilitating today's webinar, which is The Pharmacy is How Far Away? Managing Opioid Agonist Treatment in Regional Victoria, presented by Dr. Adam Straub. This webinar is part of our Connect and Learn webinars designed to support AOD clinicians within Victoria. We like our webinars to be interactive, so please ask questions via the chat function. You'll have an option after Adam presents to either raise your hand and ask your questions verbally, which is preferred, or you can otherwise put them in the chat and I will attempt to ask those for you. So all of those, time permitting, will be answered by Adam at the end of the presentation. Adam's been really kind to let us share his PowerPoint presentation today. So no need to write notes. We'll get those to you via email. All of our webinars are recorded and are later made available on the Turning Point website. At the end of the presentation, if you could please take a few minutes to complete the evaluation survey. Adam will display a QR code on the final slide. You'll also be sent an email, which you'll have the option to do it there as well. Finally, I'd like to introduce our presenter, Dr. Adam Straub, addiction medicine physician. Adam is a strong advocate for opioid agonist therapy and harm minimisation. Adam is actively involved in continuous professional development and medical education. Adam, thank you so much for your time today.
No worries. Thanks for having me. And I'm going to talk a lot about how treatment in regional Victoria specifically is interesting for patients on opioid agonist therapy and general opioid management as well. So just a little bit to help understand that our access to prescribers and pharmacies is not as straightforward or evenly spread as you would like it to be. So this data is taken from the 2024 NOPSAD data. You can see in the first table there that the prescribers, Victoria, we have 1,248 individual prescribers who provide MATOD medications. There are an additional 16 who work in correctional facilities, but we're not going to worry about those ones for today. The second table there, you can see that each private prescriber has on average 10 patients that they prescribe to. So it's not a lot of patients. The workload is generally spread fairly well on average. And that's the important part here. Because when you look at the actual breakdown of that, 60 of that 1,200 prescribers have 0 patients that they're treating. The vast majority, well and truly beyond everybody else, 827 have between 1 and 5 clients. Now that's, various different prescribers within the city, scattered throughout regional Victoria, but not too many people that are carrying a large workload. And that's actually beneficial for a lot of people because you don't have that many you have to worry about. If one prescriber goes down, there's only a couple of people that need to be absorbed other places. That being said, when you look further down that table, you have a number of us that are carrying quite a few patients. 72 that have between 26 and 50, 44 that have between 50 and 100. And there are 73 prescribers in Victoria that carry more than 100 patients. So you can imagine if any one of those doctors or nurse practitioners gets unwell, has to, retires, whatever, there is a huge impact in that local community. So it's not as nicely spread as we would like it to be. That 827 that have 1 to 5 bring that average right down. And what about our dosing points? Well, in the state of Victoria, we have 781 pharmacies that patients can go to have their dosing points. That sounds like a whole lot, especially when New South Wales only has 850, so not that many more than us. But what does that actually mean in terms of where can our patients get their medications from? Well, it's not that evenly spread. So taking this from the NOPSAD data, areas that are gray, there isn't any data from. So some of this is a little bit hit and miss. But the important part is that you have big, big chunks of territory where there is either zero or only even one pharmacy. Especially when you look here in the northwest of Victoria, you start to have fewer and fewer. There are a few scattered through up towards Mildura, Swan Hill area, there's a couple there. Ballarat, Bendigo, you've got a few extras. But when you look at the big, big chunks of territory, there are some very important gray spots and very light blue spots. The gray spot in the west here surrounding Horsham, there's no data because there are no dispensing pharmacies. Horsham is the only one in that whole gray area. So it becomes very tricky for patients in that space, and I've got quite a few of them. What does that mean compared to Metro Melbourne? As you can see, there's a huge amount of area that doesn't have any data, but most of Metro Melbourne, you've got lots of little areas that have, 5, 6 or more pharmacies without a great distance that people have to travel. So you've got a lot more pharmacies concentrated in metro regions rather than the broad spread of people way out in regional Victoria. I'm not sure why there's so many gray areas. It is, from the data that was gathered with NOPSAD. So it may be that in these areas there aren't pharmacies that dispense. It may be that they just didn't respond by the time that the data collectors were doing their information. Okay, so what about me? My service area covers most of Northwest Victoria, the Grampians and Loddon Mallee regions. I'll show you in a picture what that looks like in a minute. But it is roughly 160,000 square kilometers. There's about 750,000 people that live in that whole area. And in that territory, there is one Fatcham Fellow, me. There are a few other prescribers. There's some GPs who have done some MATOD training. There's some GPs who haven't done formal MATOD training, but do a little bit of buprenorphine and long-acting injectable. And there's a few nurse practitioners. But that being said, there's not enough. A lot of the GPs are aging, retiring. The ones that do cover as much as they can are overworked. There are clinics that you can't get onto MATOD medications because the GP who services that area doesn't have any appointments that they can get any new patients onto the program. There are a bunch of folks that are moving out of public practice and moving into corrections practice. And so they've done a little bit of work, but then they disappear because they go off to other jobs, other regions of Victoria, etc. And so there's a significant dearth of prescribers and practitioners in the Grampians and Loddon Mallee regions. So as I said, what does that actually look like? You can see on this map of the PABIN network. Metro, you've got the Northwest Metro and the Southeast Metro. Regional Victoria, you have officially 5 PABINs, the Grampians one, the Loddon Mallee, which are usually combined into one, Barwon, Southwest, Hume, and Gippsland. And you can see that if I'm currently working in the Grampians and Loddon Mallee regions, how much of the Victorian territory my practice actually covers. So what does that actually mean for my opioid clinic? My opioid clinic started in July of 2022, and to January of 2025, we had more than 350 referrals of unique patients in that 2-year period. There were 211 different medical practitioners who referred patients into our clinic, and you can see the heat map down in the bottom right here, labeled Figure 1, where the referring practitioners are from. You can see the 2 bright red spots are Ballarat and Bendigo, but then you can see other hotspots even as far down into Metro Melbourne, Geelong, Horsham, Ararat, Stawell, Swan Hill and Mildura up along the border, and Echuca are the main hotspots there. So you can see that patients have been referred all over Victoria. And yes, that hotspot over in Wangaratta is a real one. There have been a few patients referred over from that region. In the other figure over on the left-hand side of the screen, you can see where those 334 or the 350 plus patients have been referred from. And we have seen at least 334 patients at least once between July 2022 and January 2025. And you can see on that heat map there where all those patients have come from. So even if there's not local GPs in all of that area, they've been referred from all over regional Victoria, some of them all the way down into Metro Melbourne. A lot of those are people who have been in Metro Melbourne in some of the big hospitals, who have then come back out on opioid agonist treatment or otherwise, who have needed to be reviewed in my clinic. So you can see there's huge amounts of territory that these patients are coming from and so many different GPs. And as you know, this data is only to January of this year. The month of July of this year was one of our busiest, where I was getting one new referral almost every single day. We had 28 referrals for the month of July. Now, in the opioid management clinic here in Ballarat, there is one medical practitioner seeing patients, yours truly. Started the clinic in July of 2022, and between July 2022 and March 2023, we were seeing 4 hours of clinic per week. The demand got so big, we asked the Department of Health for some more funding, so they did. We doubled my hours nearly, and for the almost the whole year of 2023 to 2024, I was working 7 hours a week seeing patients. At the end of 2023, the Department of Health said, hang on, your workload's even increasing. There's so many people who are asking about it. Can you increase it any more? So I shifted some things around, and from January 2024 until present, my opioid management clinic runs 15 hours of outpatient sessions per week. So we see quite a lot of patients. What does that mean in terms of actual numbers? Well, even taking in mind that the 4 hours for 2022, 7 hours a week, 2023, between July 2022 and January 2025, we had 1,760 appointments. 440 of them were face-to-face, and 1,320 were telehealth appointments. Because I cover such a huge area, I cannot expect patients to be coming 4 to 5 hours drive each way just to see me for half an hour or more. And so we make it easy to access, and that's why there's such a huge proportion of telehealth appointments. That being said, we run a pretty good ship. The attendance rate in the clinic is sitting just under 95% of attending for all of those appointments. It is a rare thing for me to see patients not show up to my clinic. And it actually prompts us to go, hope they're okay, because they usually show up. That being said, as I said, the workload has continued to increase. More and more referrals have been coming in. And as of last night, the next available new patient appointment is the 12th of December of this year, which is not ideal. We'd really ideally like to get patients in between 2 to 4 weeks. 2 weeks is better, but now we're sitting at about 6 weeks before a new patient can be seen in clinic. And the demand keeps increasing. We've had additional requests from other PABINs of can we take some of their patients as well? And we're working on all of that. So how do we actually make it work with such a huge territory? We've got to be flexible. We've got to know that people can't come all that distance, but we have to be able to figure out, what do we do? Figure out who needs to be seen face-to-face, like who do we really have to have that way? People that live locally, we often say, hey, can you come in for the first one? That'd be great. I've even got an outreach clinic that I do one Friday every second month. We run the opioid management clinic out of Bendigo Community Health. So yeah, one Friday every couple months, we go over to Bendigo and we see patients face to face all day, so that they can actually get that contact. They get the physical examinations, etc. And it helps for patients who don't have a lot of access to internet service and things like that. The large portion of our appointments are telehealth video chats, similar to what we're doing here, only the patient gets to interact back easier, which is very helpful. It does not work as well in some of the more rural patients, more remote areas. And so sometimes what we do with those is we get the patients to go to their GP who's done the referral, and we set up with the GP practice saying, hey, we need this patient to come in, use a room, use a computer so that I can chat to the patient using your hardware because their network service isn't good enough and it's too far for them to drive to the clinic. About half to 75% of the time, the GP will actually attend the appointment, which is often quite useful because the patient gets to open up and say all the things that they need to say, and the GP gets to see the interaction, learn from having those difficult discussions, and learn, what kind of questions I want to ask and need to know the answers to. And so it's really quite helpful when the GP does show up. Sometimes I kick the GP out so that I can actually get, more honest answers depending on the patient. We also do quite a few phone call follow-ups, which are more common for our things that are, patients that are stable on opioid agonist treatment that we're catching up with every, 4 to 6 months. Say, how's everything going with your Suboxone, your long-acting injectable doing okay? Any questions? So we have a bunch of those as well. How do we make the rest of the interactions work, and why do people actually listen to what we say? We have a lot of practice meetings where one member of the PABN, the Pharmacotherapy Area-Based Network, goes wherever in regional Victoria, in our area, to a GP's practice, is there face-to-face, has all of the pamphlets, the information about MATOD training, the information about the PABN, information about my clinic, and then I do a Zoom-in meeting like this, where I talk to the GPs about what we do in our clinic, what kind of things we can help look after for their patients, and allow them to ask questions so that they get to know that there is a specialist in their region that they can ask questions of, rather than some ethereal, there's a specialist in Melbourne somewhere who I've never met and I don't know what they look like. They actually get to know who I am, and they know that they can actually talk to somebody, send us emails, ask questions to the clinic when they're not sure what to do. So we do a bunch of those, and that increases that awareness, increases the comfort level that they know that there's somebody supporting them. We also set up a lot of meetings with the regional pharmacies so that we can build those relationships and link people into services, and so that the pharmacy knows that when they're talking to somebody or they get an email from me, they actually know who they're talking to. And they know, okay, he is specialized, he's got this knowledge. All right, I understand what he's trying to say here. Okay, I'll work with this, I'll work with that. As a prescriber and MATOD provider, it actually helps me because then the pharmacist knows that they can easily get back in touch with me and say, hey, I'm worried about Joe. Things are causing problems here. Or, Mike hasn't shown up for a couple of weeks. What do you want to do about his Suboxone? It makes that familiarity with the specialist and the prescriber so we can develop that good relationship to help look after our patients better. And then we also provide clinical network meetings across the entirety of the region. They happen every few months, and either one of us will go or we'll present with somebody locally, or we'll do a Zoom webinar kind of thing like this. There we go. Now, how is some of this practically going to work for our patients? I showed that picture of the regional pharmacies and things. How are we actually going to get something? So, like, if you imagine you've got a regional farmer, they've got a big sheep station. They've had lots of injuries over the years. They've got a bit of worn out body. Their opioid use has slowly escalated over time, showing signs of, tolerance, maybe some withdrawal symptoms. They've got, maybe they've asked a little bit early, or, they tell their GP, hey, I've had to use a few extra endone this month. Maybe they come into the GP and say, hey, I'm sick of taking all these pills. What do we, how can we do with this? But they also live, like 45 minutes or more from the nearest pharmacy. How are we going to make this kind of work if we're shifting them onto opioid agonist treatment? And especially if they go like, I don't really want to change if I'm going to have to go to the pharmacy every day. I don't have time for that. I'm too much work. I'm too busy. The guidelines say daily dispensing for the first month or 3 months. If it's 45 minutes to the pharmacy, you're asking somebody to drive an hour and a half every single day. So how are we going to think about this, and how are we going to work all of these things? Well, some of the things we think about those are guidelines. They're not hard and fast rules. We are, as prescribers, allowed to rationally discuss it with the patient, with the pharmacy, talk about what our risks are, what are the things that we need to worry about, what are some of the practicalities, because if we say, he's not going to go to the pharmacy, so he's not going to do this treatment, then we can't say this is the only option you've got. So we need to think about the things of why do we need to worry about him? Do we need to get him onto medications for like MATOD medications? And what are our barriers to transitioning that we can come up with? And how do we work around them? So why do we need to worry? Well, if he's increasing his opioid use, if he's got other medications that are on board, does he have risk of oversedation? Is he starting to get higher and higher reassured scores? And we need to worry about, just the impact from the opioids themselves and his risk of, being found one day. Does he have other medications that could be impacting on his opioids and the risk of oversedation, respiratory depression? Is he an isolated farmer who's got no close contacts? He lives out in the middle of, 500 acres. Does he have any social supports? Like, who is his nearest neighbor? Who's his next of kin? How often does he, contact people? Does he actually have ongoing pain? Are there things that he's going to run into problems with that we need to take into account before we say, no, too bad, you need to go on to MATOD instead? Does he have risks of further injury? Is he still running, big heavy machinery? What is he doing? What risks are there that if we put him onto Suboxone, for example, is he going to have pain? Is he going to have acute injuries? How are we going to manage those things if and when they happen? Should we shift him over to MATOD? Well, what are his risks of overdose? What are his risks of oversedation? The methadone and buprenorphine medications have longer durations of action. If we say he's got an opioid-reliant pain condition, they might be working better because they have a longer duration of action. Some of them do have a lower risk of overuse. If you've got fewer takeaway doses, or even if you're looking at long-acting injectable, you can't overuse that because you only get it when you get it. There are options for changing his treatment with the long-acting injectable. He doesn't have to go to the pharmacy that often. So what do we need to think about, and how do we need to work about shifting him over to MATOD? What are our barriers? How far is it to the dispensing pharmacy? If we follow the guidelines, 1 to 3 months of daily dosing in the pharmacy before he's allowed any takeaways, that's really going to limit a lot of, that stuff. And, he's shouldn't have very many takeaways in the first few months, which may keep him from engaging in treatment because he may find that it's too much of a pain in the backside getting to the pharmacy. It may be too expensive just going back and forth to the pharmacy. If he's driving an hour and a half, 200 Ks every day, it's going to, cost him a fortune. All the time requirements where he's not on the farm. What is his actual pure pig-headed stubbornness of, no, I don't really want to do that, and it's a pain in the butt, so I'm not going to do it. Is there the potential for perceived medication failure that, this hasn't worked, or, we put him onto Suboxone or long-acting injectable, and it doesn't do as much for his pain as, the Targin did or the OxyContin did, so it's not working, doc. It's not doing things. Do we have that issue where he then just gives up on the whole thing? If he's isolated and we're shifting him from whatever full opioid agonist over to a buprenorphine-based medication, do we have those risks of withdrawal? How fast are we shifting him over? What happens in somebody who's got pain as an isolated person? What's going to happen there if we say, you're dependent on these opioids, we're going to put you on something else, and he's still in pain afterwards? How is that going to impact somebody who's socially isolated? And, we know that a lot of our more rural and our farmers have higher risks of suicide. Is he going to get into a bad place mentally and not really tell us because we haven't treated him with the perceived respect and thoughtfulness and just forced this medication on him? So there's all these issues we have to think about. So how do we keep our engagement with these patients? Well, I've got a few rules that I stick by. Rule number 1, they're human beings. They're not a number. They're not just a random face on the screen. They're not a disembodied voice over the phone. There's a person there that has health conditions, that has medications, that may have dependence, that may have things that we need to treat, who has experienced a lot of vulnerability. These medications are highly controlled. A lot of regional practices are only dispensing a fortnight at a time. You have to go to the GP every fortnight to get a new script, so you go to the pharmacy to get a new script dispensed. And if your GP is away or you miss your appointment or whatever happens, you're at risk of running out of your medications. So they're worried about this, and they've got that vulnerability of going into withdrawal, getting in more pain. And so they're, vulnerable. And stigma really, really sucks. Almost every single patient that I've treated in my clinic has experienced the stigma of being on opioids, of going to the doctor and feeling like you have to beg for your medications, being worried that people are looking at you funny, being worried that the GP thinks you're overusing these medications because they've seen all the TV ads and the commercials and the movies of people who overuse their meds. Going to the pharmacy and going, yes, I still need my opioid medications. What happens if they get put onto Suboxone or methadone? They have to go and stand in that queue where all of those druggies stand, where you then get treated differently because you're dependent on opioids. And if we're changing things and it makes people feel a bit icky, or we change the rules of how often you have to go to the pharmacy and all of that stuff, we're adding inconvenience, and a lot of people just don't respond well to those inconveniences. So we need to think about all of those pieces that are moving for this person. And we have this perceived power over them of, we're going to change everything. We're going to make all of these things different, and you're not going to have a lot of choice. We need to understand that they are a vulnerable person who's in a really bad spot, that we need to do our best to treat them with kindness and compassion, so that we can then look after how we do stuff and how they progress as people, both in terms of pain, but both and also in terms of their opioid agonist dependence treatment. All right, so this is where we start some of the open, you're allowed to talk phase, and ask some questions, because I'm going to ask some questions of you guys. So hopefully, what we're going to try to do is we're going to try to unmute everybody. And if it works well, then just chime in, ask your questions, come up with some answers. If it doesn't, or you don't want to just spout off, just raise the hand thing, and Rebecca or somebody will point you out, and we'll be able to ask questions. All right. So first case, JA, 31-year-old lady, had an injury 10 years ago. She's got a chronic wound. She's had a skin graft that's failed and has daily dressings, and it's a pain in the butt. She lives out in Minime, Vic. When I first heard about this lady, I had to actually look up the city and figure out where the heck it is. It's the nice little star there on my map. The local pharmacy will dispense some opioid medications, but they won't do Matod. The closest Matod pharmacy is in Horsham, which is on the far right-hand side of that map. It's about an hour and a quarter to get there. It's 100 kilometers, okay? So we've already got somebody who's in a bit of a tricky position. Her current medications, when I've met her, was oxycodone immediate release, 20 milligrams 4 times a day. Tapentadol immediate release, 100 milligrams every 3 hours, PRN. Methadone at 75 milligrams a day. And on top of everything, some pregabalin at 300 milligrams twice a day. Okay, so keep that medication list in your mind. I'm going to go back to the slide that's got her picture on it. So what do you think? What are going to be some of our concerns with this lady? Yep, this is how this patient came to me, by the way. They're not on all of this now, but this is how they came to me.
There was a comment about the hyomed and mobility and transport and sedation.
Yep, so not sedated at all, even with all of this. Cares for 2 young children at home. Husband works full-time. She's able to drive. And when I first met her, was driving to Horsham once a week to pick up her methadone. So she was getting 6 takeaways. So 1 live dose in the pharmacy in Horsham, and then 6 takeaways. Cool. So anyway, what we've done with her, she's shifted over to Sublocade. So she's entirely off the methadone, entirely off the oxycodone. Her tapentadol is now 50 to 100 4 times a day, mostly because she gets really nasty breakthrough pain whenever she's doing any of the dressing changes. And her Lyrica is down to 50 milligrams twice a day, I think. So she's made significant progress in the last 12 months. All right, case 2, Mr. KH. A 68-year-old gentleman, heavy machinery worker, way out in the middle of nowhere. He's had lots of minor injuries over the years, lots of sciatica. mostly just that repetitive heavy machinery bouncing up and down kind of stuff. He's had a bunch of nerve root injections. I think he even had a spinal cord stimulator in at one point. Things have just not done real well for him. He lives in Sea Lake. His nearest pharmacy is in Swan Hill, 45 minutes drive away from him. When he came to me, he was on OxyContin 40 milligrams 3 times a day, and endone 5 to 10 milligrams QID PRN. And literally his words were, "Doc, I want off all this shit." He had heard about long-acting injectable, spoke to his pain specialist, and his pain specialist said, "I'm not sure I know much about it, but I know a guy who does." Any opinions on this guy? What would we think about with him? This chap, over about 2 or 3 months, shifted him through buprenorphine patches. He's now on Sublocade. So he goes to Swan Hill Pharmacy, gets his injection once a month. Yeah, he was definitely a good fit, and he's been very successful with that. So, and finally, case 3, TC, 28-year-old chap, used to use some heroin, was on and off Matod treatment when he was in Melbourne. Been in and out of prison a few times. Last discharge from His Majesty's custody, moved up with his mum in St. Arnaud. He's not really got a great relationship with the local pharmacy because he's a little bit standoffish, a little bit antisocial. He is getting some cravings and wants to avoid going back to misusing and using heroin. So just to show you where St. Arnaud is, for those who don't know where it is, it's the nice big red star there. St. Arnaud Pharmacy does do Matod, but they don't like this guy. So we've got a little bit of an issue. What do we do about getting this guy some treatment? The other nearest pharmacies that do dispense are Horsham, down here Stawell and Ararat, all the way over here where Kangaroo Flat, and Bendigo, or all the way down to Ballarat itself. Most of them are an hour or more away from where he lives. So how are we going to get this guy stabilized? Yeah, he's getting cravings and having some issues with all of that. So we had a long chat. He opted to go over to Buvidal. But yeah, long-acting injectable buprenorphine is the way he went. And he currently drives over to Horsham because he's got friends over in Horsham. So he goes and catches up with them and sees them once a month. It's very much patient dependent. I do start them straight on them sometimes. Yeah, especially if they're more mobile and not necessarily like if they've got a longer duration of travel that they have to do. So we often will go, here's something, and then provide them some backup so that if it's not a totally sufficient dose for that first dose, say like if you transition straight to a 16 milligram Buvidal weekly as the first dose. So we sort of cover that. And they often will have a small supply of immediate release something, just to keep them out of withdrawal if it happens. The first case was a patient who was on methadone, so we shifted her through a modified Bernese transfer with buprenorphine patches. And so that way she had patches to come through and was picking them up weekly while she picked up her methadone anyway. So that was easier from that perspective. For a lot of the other ones, I do a modified thing. So I usually will introduce them with buprenorphine patches to build up the levels initially, and then shift them over to Suboxone before shifting them over to long-acting injectable. Depending on how far it is to the pharmacy, we often have a relationship with the pharmacy themselves of, hey, I want it to be 2 milligrams today, 4 milligrams tomorrow, 6 the next day, 8 the day after that. Can you provide them 4 days worth of medications with a plan to that's sent to the patient so that they know 2 today, 4 tomorrow, and then that way they don't have to go back every single day. So we make it a little bit easier and a bit more flexible with how many takeaways they have.
Is it unusual to prescribe TDS oxytocin?
Odd, yes, not out of the realms of possibility. I certainly see it in people that come to my clinic, so that there are some people who are noting that before the 12 hours is up, that they're starting to experience withdrawal and pain and things like that. So I have seen patients come in on TDS dosing of OxyContin. I try to avoid it if at all possible, um, but it is not. It does happen. Yeah, Sublocade is a monthly dose. I have had a couple of patients who will dose every 6 or 7 weeks that have done that successfully. So, some people can have a longer half-life. Buprenorphine, well, Sublocade's got an average half-life of 43 days. Um, so depending on the person, you can stretch it out. I think the PBS documentation for it says no more than 7 weeks. But it's again, play it by ear and or no more than 6 weeks, 42 days, and then see what works for the patients. But on average, it's of every 4 weeks. One of the things it's interesting in the initial phases, it was listed only for opioid use disorder.
Mm.
They've clarified a lot of it and redefined the definition for pretty much every state and territory now. That long-acting injectable is listed for opioid dependence, and they have been deliberately vague as to what we class as dependence.
Yep.
And so some people, we can get away with the idea of this person has an opioid dependent pain condition, like their functioning is dependent on opioids. And so it's the label and the stigma still exists, which is part of the conversation that I have before I enter into trying to get somebody onto these. That yes, people will think that you have misused your opioids in the past if they see you're on these medications. Are you okay with that idea? Yeah, it works. You've had the buprenorphine patches; they're working pretty well, but they're not sticking well, or you're getting a rash to the glue in the patches. But buprenorphine's been a good medication for you. We would just want to shift the mode of delivery of that medication. You are opioid dependent because you can't function without it. And people go, okay, well, that definition makes more sense. I'm not misusing things, and we both understand that. Yes, okay. And because I think the patient's opioid dependent, we can use it.
Mm.
But yes, I think if we changed the way that people thought about these medications and what they were indicated for, you would see a lot more people on it.
Thank you, Adam. I found that particularly interesting. It was interesting to see those numbers being dispersed and, when you had the amount of prescribers with, 1 to 5 clients, that was really interesting stuff.
Yeah, the more prescribers we have that even take up that 1 to 5 does help the ones that are carrying the 100.
Yeah,
Yeah,
yeah.
and the more people that do MATOD training, that have the knowledge, that, can look after this patient group, the easier it is for everybody, because you're not worried about, do you have enough backup? Are there people who are gonna be in your clinic if I'm, unwell? What happens if I want to go on leave and go overseas for a month and don't have access to my software? What's gonna happen to my patients?
Thank you so much, Adam.
Anyways,
Thank you,
thanks for
everyone.
everybody coming too.